If you're a pathologist in training, you know that feeling when a pediatric liver biopsy hits your desk. It's a big deal. Today, we're going to break down one of the most important guides you'll ever use, the CAP protocol for hepatoblastoma. We're going to turn this dense document into a practical, step-by-step guide you can actually use at the bench.
Okay, picture this. A tiny core biopsy from a child's liver lands in your hands. The request says, rule out hepatoblastoma. Right away, you know the stakes are through the roof. This isn't just about getting a diagnosis. It's about getting every single detail exactly right, because a kid's entire treatment plan is writing on your report.
So, here's our game plan for this explainer. We're going to kick things off with the why this protocol is so incredibly important. Then, we'll follow the specimen's journey, from the moment it arrives to the slide on your scope. The real heart of our talk will be decoding those key histologic patterns. After that, we'll get into the crucial extra studies before finally putting it all together in the perfect report. So why all the fuss about such a strict protocol? Well, it's all about creating a gold standard for a really complex diagnosis. You see, hepatoblastoma can look like a lot of different things under the microscope, and it has some tricky mimics that can easily lead you down the wrong path.
And that diagnostic challenge gets even tougher when you realize who the patients are. 2/3 of all hepatoblastomas show up before a child's second birthday. We're talking about infants and toddlers. Every single piece of information has to be precise because those treatment decisions have to be made with absolute confidence.
And that's the bottom line. The CAP protocol isn't just about checking boxes or filling out forms. It's a powerful tool that makes sure every single pathologist, no matter where they are, is providing the exact same critical information. That information is what the oncologists depend on to accurately stage the risk and pick the therapy that could save that child's life.
All right, let's get practical. The protocol really kicks into gear the second that biopsy shows up in your lab. So what are the very first things you need to do?
First off, the protocol is crystal clear on what kind of specimen you need. It says, flat out, do not use a fine needle aspiration. And why is that? Because just looking at a smear of cells can be super misleading. It's almost impossible to tell a well-differentiated tumor from normal, regenerating liver cells. You need to see the architecture. That's why a core biopsy is the only way to go.
And we're not just talking about any single core biopsy. The protocol is pretty specific here. It recommends getting multiple cores, ideally like 5 to 10, and taking them from different parts of the tumor. This gives you the best possible chance of seeing all the different patterns that might be hiding in there. And hey, if you can get a piece of the normal liver right next to the tumor, that's a massive bonus for checking out any other background issues.
Okay, slides are ready. Time for the main event, looking down the microscope. The protocol breaks down a few key histologic patterns. And honestly, learning to spot these is the single most important skill you'll need for these cases. First up is the well-differentiated fetal pattern. Now, these cells can look surprisingly normal, almost deceptively so, which makes them tough to pick out sometimes. But here is a critical point from the protocol. You can describe this pattern on a biopsy, but you can never call it a pure fetal hepatoblastoma. That diagnosis is only for resection specimens, after you've seen the whole tumor.
So what are you looking for? Morphologically, it's a super low mitotic rate. We're talking 2 or less per 10 high-power fields. But really, your immunohistochemistry is going to be your best friend here. Glypican-3 or GPC3 shows this really classic, fine stippled staining right around the canaliculi. And, super important, SALL4 will be negative.
Next, we have the crowded or mitotically active fetal pattern. You're going to want to get really familiar with this one because it's actually the most common pattern you'll find in biopsy specimens. So, as the name suggests, the big difference here is the mitotic rate. It jumps up to more than 2 per 10 high-power fields. The cells just look busier with bigger nuclei. But check this out. Pay close attention to that GPC3 stain. It completely shifts from that delicate stippled pattern to a coarse, diffuse cytoplasmic stain. That change is a huge clue. Okay, let's move on to the embryonal pattern. This is a less differentiated, more primitive-looking component. You'll often see it as these tight clusters of small blue cells.
The cells here have a really high N-to-C ratio, and you'll see a lot of mitoses, maybe even some rosettes. GPC3 is going to be strongly positive. But here's your money stain, SALL4. Remember how it was negative in the fetal patterns? Well, here, it's often strongly positive in the nucleus. That stain can be the thing that absolutely clinches the diagnosis of an embryonal component.
Now, I need everyone to pause here, because this is probably the single biggest diagnostic pitfall you can run into. If you see something that looks like a small cell undifferentiated pattern, the protocol is non-negotiable. You must, absolutely must, do an INI-1 stain. If that INI-1 is lost, it is not hepatoblastoma. It's likely a malignant rhabdoid tumor, which means a totally different treatment and a much worse prognosis. You have to get this right.
So we've nailed down the morphology, but our job isn't done. Ancillary studies give us that next layer of information that's just as essential for figuring out the prognosis and treatment plan.
Alpha-fetoprotein, or AFP, is the big one here. Now, it used to be that a really low AFP level, like under 100, was seen as a very bad sign. We now know it's more nuanced than that. The big international risk stratification tools use different cutoffs. That's why it's so vital that the initial AFP level gets documented perfectly in the path report.
Okay, this slide right here, this is your high-yield, must-know IHC takeaway. These are the big three. GPC3 helps you tell the subtypes apart. Beta-catenin, when it's nuclear, confirms that the Wnt pathway is switched on, a key driver of this cancer. And INI-1, as we've said, has to be retained. If you only remember one thing about IHC for hepatoblastoma, make it this table.
So, we've gathered all our puzzle pieces, the histology, the IHC results, the AFP levels. The very last step is putting it all together in a report that meets the CAP's super strict requirements.
And that means using synoptic reporting. Let me be clear, this is not a suggestion. It's a requirement for your lab to be accredited by CAP. It's a structured format that forces you to address every single critical data point so that nothing ever gets missed. A simple narrative paragraph just won't cut it.
And this is exactly what that format looks like. Data element, response. Every piece of information gets its own line. For example, histologic type, hepatoblastoma, epithelial type, fetal pattern, mitotically active, crowded. This isn't just about making things look neat. This rigid structure is what allows researchers and registries to easily pull data from thousands of reports, which is what helps move the whole field forward.
So I'll leave you with this final thought. Every time you sign out one of these cases, just remember, your report is so much more than a piece of paper. It is the definitive roadmap that is going to guide every single decision made for that child's care. Following the protocol isn't just about meeting a standard. It's about building the strongest possible foundation for a cure. So ask yourself, is my roadmap as clear, as complete, and as correct as it possibly can be?